Welcome to ATR 387. This course is titled The Evaluation of Lower Extremity Injury. However, before we can get to specific joint evaluations, what we really have to start with is the basic understanding of the injury examination process. To me, it's one of the major key components to being able to get to the patient's diagnosis, right? And so any good clinician, any good athletic trainer, any good physical therapist, any good physician's assistant will have a thorough understanding of the injury examination process before they even begin to examine their patients in the clinic. And so this is going to be stop number one in this class, is building the foundation before we start to build our skills. So a good injury examination evaluation technique really is one that is going to be systematic in nature. And there are 22 of you enrolled in this course, and so each of you will be individual and each of you will have your own way to evaluate during patient assessment. However, whatever that individual choice is, it always should be systematic. And when we think about an examination or a patient evaluation, really there are three components that fit into the evaluation no matter what you start with or where you begin. These three components typically make up the overall evaluation. And so the first component is the what we would call the objective data or the objective measurements that we might obtain from our patients. And most importantly are what we would consider a baseline measure from our patients. And so when we think about baseline measures are the initial objective data, the initial numbers, the initial range of motion that we might get from a patient. It allows us then to compare back to, it allows us to set goals in our rehab, in our treatment. It allows our patients to also see if they've improved, if they've digressed, if they've plateaued. So your baseline measurements are really key components to the evaluation technique, and you should be thorough when you're doing your objective data assessment and measurements. And so your baseline measures could include, but are not limited to, doing patient re-evaluation, so follow-up, so asking about their pain from a day-to-day basis, measuring their range of motion on a day-to-day basis, etc. Your objective data will include any rehabilitation and or treatment protocols that you might be doing with that patient. So for example, if you're heating your patient every day, that is something that you're going to document and assess every time that patient comes in. Are they feeling better with that heating? Are they getting worse with the heating? How are they feeling with the treatment and the rehabilitation that you're doing with them as well? Another component in the injury evaluation process, probably the most underestimated component, is the process of documenting what it is that your patient tells you and what it is that you also observe during your evaluation technique. And so when we think about documentation, every documentation or type of documentation will differ from clinic to clinic. It will differ from facility to facility, but documentation includes your patient's medical records, right? And what we know now is that most facilities are moving to an online form of documentation. However, your older, slower developing facilities and or clinics may still be using the handwritten form of documentation. When we deal with patient populations, what we need to know about documentation, number one, is that it is required legally by the state and or the government to actually document any form of treatment that you might be doing with that patient. But the biggest facet of documentation, even though it's burdensome and it's tedious, is really it serves as a communication tool between the patient and also from clinician to clinician. So we might imagine that clinician A works with patient one day, but then he or she's not in that day, and so clinician B picks up the patient's documentation. So it serves as a communication tool to the next clinician picking up that chart. So it's very important when you're documenting to be very thorough in that process, because you want the person picking up that chart to be able to duplicate whatever it is that you did with the patient on the previous day. So as you're gathering objective data from your patient during their baseline measurements or follow-up measurements, there are really two evaluation strategies that clinicians kind of use. And the first strategy, which is the most commonly taught strategy, would be to perform each task on the uninjured limb first. However, we still have clinicians that actually perform the task on the injured limb first. Here's my only caveat with that. is that when you perform a task on the injured limb first, if it causes pain, it also causes apprehension in your patient for the rest of the evaluation. And so my recommendation to all clinicians really truly is to perform the task or the range of motion or the special test that you're going to be utilizing on the uninjured limb first. One, it allows your patient to become familiar with what it is that you're going to be doing to the injured leg and or limb. And the other thing that it does is it reduces patient apprehension as well. So again, my recommendation would be to perform each task or measurement or special test on the uninjured limb first and then move to the injured limb second. Now, here's the other advantage that I believe we get as clinicians when we use the uninjured limb first. It allows us to see or observe how much range of motion, how much flexibility that patient has in that limb when compared to the injured limb, and it allows us to do a side-by-side assessment. When you go to the injured limb first and then you compare it to the uninjured limb second, it just becomes very difficult to look at the deficits that patient might have in the injured limb. So your injury evaluation really is going to depend on the setting. In the clinical setting, what we typically have is the clinical assessment, which is when our patient comes to us in the clinic and needs to be assessed. And then we also have on the sideline, right, where we're covering an event or we're covering a sport, and our patient gets injured right on the spot, right? And so we would consider that to be an acute evaluation. When we do a clinical evaluation or an assessment versus an acute evaluation, something that's right there in the moment, there really are major differences. When we think about a clinical assessment, we can take our time, right? Our patient comes into the clinic. We have more than enough time to go through our entire systematic evaluation. When we look at the acute evaluations, however, we really are under a time constraint, right? Because we could be dealing with a coaching staff that needs to know if this player can return to play right away. And so in the clinical assessment, we can be very thorough. However, in the acute assessment, we have to be thorough, but we also have to shorten our assessment and basically use the major objective data and subjective data to determine whether or not that patient can return to play. So when we ask the question of, what are the major differences between an acute assessment versus a clinical assessment, the major difference is time. How much time can you spend with the patient trying to figure out what their pathology or their illness is, right? In a clinical assessment, we're going to say that time is going to can be long, and then in an acute setting, what we say is, it's very short and it's very rapid. In acute evaluation, it really requires you to be very skilled in injury evaluation, and it requires you to be even more systematic because it's during acute evaluations, because we're under a time crunch, that we might forget to do something that's vitally important to rule in or to rule out the pathology in that patient. So during a clinical assessment, when we have time to spend with our patient, there are special considerations that we need to take into account. And some of those special considerations, probably the number one special consideration, is really discretion. I think it's most important when you're dealing more so with female athletes or female patients than with male athletes or patients. But it's this idea that when you're working one-on-one with the patient, that you are very discreet and quiet when you're assessing them and when you're discussing their pathology / their illness. One thing that I have encountered over the years is being conscientious of a person's religion, right? At Point Loma Nazarene University, most of the patients that you might encounter would typically be Christian. However, when you move outside of Point Loma Nazarene University and you're starting to work in physical therapy clinics, or you're working in a medical facility, or you're working at a local high school / college, what you might encounter are different types of religious backgrounds. And one such religious background that I've encountered, which is very interesting, is the religion of Seventh-day Adventist, right? And so in the religion of Seventh-day Adventist, sometimes they prefer to have a same-sex clinician working with that patient, or they might, if they require any blood draws or any blood transfusions, what you might encounter is that it has to be prayed over or very sterile. So we always want to take into account a patient's religion. And then last but not least, we need to make sure that we have some type of consent from the patient that we are getting ready to touch and to evaluate. That could be in the form of a signed written statement. It could be, asking them, hey, can I help you? Can I evaluate your injury? And then in the case of an emergency medical care, so acute injury, you have this thing called informed consent. And what informed consent basically states is that you assume that the patient would want you to help them given their situation. And so in athletics, I'm not sure about physical therapy or in a medical facility, but most physical therapists and physician's assistants and athletic trainers tend to work within the same healthcare system. And so what most medical professionals will do is pretty much have their patients sign a written consent form prior to entering their facility, prior to entering into their medical clinic, etc. So that patient always gives consent for any treatment that might be done during that particular patient session. So we've kind of talked about the different components to a thorough evaluation, right? And so we've said you need objective data. We definitely need patient documentation. We have to have some type of evaluation strategy. Are we going to start with the uninjured limb? Are we going to start with the injured limb? And then we kind of differentiate between a clinical evaluation and an acute evaluation, right? But one of the biggest components, probably the most misunderstood component to a great injury evaluation process is the patient history. And so when we think about the patient history, it is really comprised of several different components, and I'm going to break those down for you over the next few slides. So you might be saying, well, why is the history so important? Why is it one of the most important components in the injury evaluation process? And so when we look at this checklist, the major reason that the history is important is because it, first of all, allows us to identify, number one, the mechanism of injury. So how did the patient get injured? Which is important, right? Because that can kind of tell you which structures might be compromised or might be injured, right? The other thing that a thorough history does is it helps to identify any past medical history. And so we think about past medical history, any previous injuries that they might have had, any previous illnesses that they might have had. And then last but not least, it also tells us something that is often overlooked, and that is what impact does the injury itself have on the patient's life, right? And we think about this more so from an athletic perspective where we're dealing with a younger population. An injury sustained during the season or during preseason truly could have an impact, right? It could lead to depression, it could lead to isolation, it could lead to, your patient losing their scholarship. So the history is vitally important because of these four factors: the mechanism of the injury identification, it gives us any prior history, it allows us to assess the actual pathology itself, but most importantly, it allows us to see how will this injury impact the patient's life, season, etc. moving forward. So the history component to an initial evaluation requires us as healthcare professionals to really have good communication skills. And so it's one of those things where when we're asking questions, we really want those questions to be open-ended. And so instead of saying, does it hurt? The patient can say yes or no. But you really don't get an idea of where it hurts, the type of pain they're experiencing, right? And so when we do a history or when we take a patient history, it's important to ask open-ended questions. Do you have any pain that is sharp, shooting, dull, achy, or etc.? Please describe the region of that pain instead of just asking them if they have pain. Patients are more apt to give you yes and no answers, and unfortunately that doesn't help us with getting a thorough history. And one prime example is I was working with a cross-country athlete last year, and I was really trying to figure out why she had such bad tibial pain. And so, do you have pain? She said yes. I said, where do you have pain? She said, right there. Do you have pain with walking? Yes. Do you have, I kept going through all of these things, and it was just yes, 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 no, no, no. When I get to the final part of my history, I couldn't figure out the injury because it was just all of her answers were all over the place. So I finally said, well, have you ever had a stress fracture before? And if so, when? And she said, yes, I've had a stress fracture before 2 years ago. This is presenting like the same thing. And so the importance of open-ended questions, it allows your patient to open up with you. It allows you to, again, identify any past medical history, that your patient may have had. So these two kind of go hand in hand. So the next question becomes, taking a thorough history is very important because it identifies several different factors. We've talked about that on the past slide. And now it becomes a question of, okay, how are we going to identify patients who walk into our clinic and have a history of injury and or illness? And then what type of questions would we ask to probe and get at what type of history they've had? And so our first stop really is with the physical examinations, or what we would call the PPEs, right? Every healthcare facility, at least in athletics, will require every athlete to go through a thorough pre-participation examination screening, which is called a physical examination, right? And since you guys are all students and have been admitted here, my assumption is that you at least had to have a physical examination upon admittance to Point Loma. And so we know what this process looks like. But why do we do the process of a physical examination? Because one, it allows us to identify upfront what health conditions the patient might have, because our patient is self-reporting these things. It allows us to see previous injuries or any other predisposing factors, such as our patient might be anemic, our patient might have sickle cell because that runs in the family. And so you might say, well, what kind of questions could I ask during an evaluation process? And so one of the major questions that we ask, athletes and or patients would be, is there a history of injury to any body area? Have you ever had an injury like this on the other side? Have you ever had an injury ever before in your life? And, if you get the yes, I have, then the next step of questions would be describe and compare that current injury. Do the current symptoms that you have duplicate the old symptoms? And what you will get is a yes, they do. It's very similar. I've had a fractured bone before, so I know that I have a fracture now, or no, this is completely different, right? And what this allows us to do is to kind of focus in on the pathology. It allows our patient to participate in the evaluation process so that they're not getting bored with this process, because it is long and tedious. So moving on in terms of history questions, right? We've kind of already have asked the patient, have they had a history of injury? We've asked if they had a history of injury on the other side. Kind of asked them to compare the types of feelings that they're having with this injury versus another. But one of the most important history questions that you might ask is, how did they injure themselves? Or what we would say as healthcare professionals, what was the mechanism of injury, right? And so let's take a few examples. If a patient sprains their ankle, right, most times they roll their ankle inward. The mechanism of injury in lay terms would be, I rolled my ankle inward. The mechanism of injury for us healthcare professionals will be plantar flexion and inversion, right? So what we want to know is not only how did the injury occur, but was it a macro trauma or was it a micro trauma, right? And so differentiating between a macro trauma, that's something that's acute, it's a one-time blow to the injured area, versus something that's a micro trauma, something that is repetitive and it keeps happening over and over and over again. When we think about microtraumas, the number one injury that's associated with the microtrauma would be a stress fracture. During this part of the injury evaluation, you also want to be probing your patient and asking them if they heard any sounds or sensations. So a lot of times you will say, did you hear a snap, a pop, a crackle, I don't know, any other type of sound or sensation, any numbness or tingling that you felt when you injured the area. You want to know what they felt when they actually got injured. And then you also want to know whether or not, again, it was acute, meaning it was more of a micro trauma that occurred, or whether it was chronic, right? Meaning it was something that was more micro trauma or micro traumatic in nature. So again, acute meaning micro trauma, and then chronic meaning micro trauma. How long did the symptoms take to occur? How long had they been doing the task? Those would be questions that you would want to ask. So after you've determined the mechanism of injury, if they've heard any sounds or felt any sensations, and you've determined whether or not it was acute or chronic, the next thing or area that we want to assess in our patient is the pain, right? So most patients present to us either because they have pain, they can't do something that they wanted to do. And so with pain, we have to be very specific. So we want to know where the pain is, but we also want to know what type of pain a patient might be having. And the most common types of pain typically are going to be either sharp, dull, and or achy. You also want to know if they have referred pain or radicular pain. And so we think about referred pain, the most common injury that occurs that causes referred pain is the liver. Typically you can get pain to either the upper left and or upper right shoulder, in addition to pain in the upper right quadrant of the abdomen. You can get radicular pain, and radicular pain, again, we kind of associate that with nerve pain, so some type of nerve pathology. And then you can also have patients who only have pain, let's say, when they wake up or in the afternoon or when they're going to bed. And then we want to know what makes the pain worse and then what makes the pain better, right? Lying down makes me feel a whole bunch better. Walking upstairs makes me feel worse. It increases my pain. And so I try to avoid that and not do that anymore. In addition to pain questions, what we also want to know is, are there any other signs and symptoms that your patient might be presenting with? And then have they had any treatment? So have they taken any ibuprofen? Have they iced it? Have they elevated, have they put an ACE wrap on it? And then last but not least, what we also want to know is what types of disability and or limitations have occurred as a result of the injury. So, let's think, you're all students, right? If you sprain your ankle, I can't walk to class because my ankle hurts so bad, or I need crutches to get around campus, or I can't sit still in my chair for very long because I get numbness and tingling that goes down into my hamstrings. So we also want to know is not only the pain, but also any disability and or limitations that may be as a result of the injury that occurred to our particular patient. So far we've said components to an initial injury evaluation would include objective data. It would also include being good communicators, taking a thorough history, and then next in that sequence of things would be your inspection of the patient. And so I kind of break this down into the immediate observations, and then I also break it down into the physical examination observation. So this is going to be what you do when the patient sits down on the table and you begin to evaluate. And then the immediate evaluations or observations is going to be as soon as that patient starts to walk into your clinic, what do you observe from him and or her? So injury evaluation doesn't begin when our patient sits down in front of us on the table. It truly begins when that patient walks into your clinic. You immediately begin to observe either their gait, their posture, etc. And so when we think about immediate observations, what things could we observe when they enter our facility? Well, the number one thing that you could observe if it's in a lower extremity injury would be their gait pattern. If it's an upper extremity pathology, then you could look at their posture, and then you could look at their ability to function, right? To hop up on the table or to push themselves up on the table. You could look at whether or not they're guarding. So in the lower extremity, typically that presents itself as some type of limp or an antalgic gait, and whether or not they're actually splinting the injured side. So whether or not they're using a crutch or a cane, or they're hopping on it, etc., to avoid applying pressure to the injured limb. So immediate observations just allow you to get a quick, acute snapshot of what you might be dealing with before your patient gets on the table. When your patient gets on the table, then your physical examination, the actual objective data and the history taking begins. And so the physical examination phase, what we want to look for first and foremost is we want to observe the patient for a deformity. And this deformity could be subtle. It could be something as simple as just feeling maybe a little divot, or it could be something that's gross or large in nature. So for example, a dislocated ankle or a dislocated knee, that would be something that's obvious to the human eye. Then what we also want to look for is swelling, right? And so I use this term hemarthrosis. And so hemarthrosis, if you break this down, it would be heme meaning blood, and then arthro meaning joint. So what you're going to basically be looking for is blood in the joint, right? And if we look at this ankle model here, we kind of see some bleeding over the anterior talofibular ligament, which would represent some type of blood within the joint. And then we also want to assess edema, what we would call edema and or swelling, right? And so we can kind of see that this is an ankle sprain that is hugely swollen one day post mechanism of injury. And so one of the things that we can do in our objective data is take a girth measurement, which is to measure the size of this ankle here to the size of the uninjured ankle to see how swollen that patient's limb actually is. So two other things that we want to inspect are the skin. We want to touch the skin first and foremost to make sure that it's not swollen or that it's not warm to touch. And one thing that we worry about if the skin is warm to touch is truly an infection. It's probably one of the #1 signs and symptoms of an infection in the lower extremity that is not post-surgical, and that would be increased warmth in the skin. So after we've inspected the patient, the next part, probably the most commonly used part of injury evaluation, overused part of the injury evaluation is patient palpation, right? And this is when we begin to kind of touch the injured limb to determine what types of pain, what types of swelling or deformities that the patient might have. And so when we think about palpation, we think of touching, right? We define that as touching the patient or touching the injury. However, let's back up a step and say, when we perform palpation, we really need to be systematic about that as well. So we're going to be systematic about the injury evaluation process, but then again, we're also going to be systematic about how we palpate our patient's injured structure so that they aren't apprehensive or they do not become apprehensive during the initial evaluation process. And so palpation always is performed bilaterally. Even if it is obvious what the injury is, you always palpate the uninjured limb first, just to determine where the anatomical structures sit, and then you palpate the injured limb second, okay? There are two types of palpation sequences that you typically can use as a healthcare professional. The first type of palpation sequence is going to be the sequencing strategy #1. That's when a clinician chooses to palpate in this particular order. So they're going to palpate all of the bones close to that injured limb. They're going to palpate all of the ligaments next, and then they're going to go muscles and tendons. However, you may not like that strategy. So there's a sequencing strategy #2 where you palpate all of the structures. However, you begin away from the pain site, and then you progress slowly toward the suspected injury or the site. One thing that I like about sequencing strategy #1 is this. It is very systematic. You palpate all bones first. Once you're done with all of the bones in that anatomical region, you go to all of the ligaments. Once you've assessed all of the ligaments in that anatomical region, you go to muscles and tendon. What this does is it allows you to be thorough without missing any anatomical structures. When you are a novice and you begin to palpate and you begin to assess patients, it becomes easier to miss anatomical structures using sequencing strategy #2. So I, as your professor, will train you up and teach you to use sequencing strategy #2 or sequencing strategy #1. And as you guys become skilled clinicians, you can choose to move away from the bone, ligament, muscles, and tendons approach and into the more global palpate all structures approach. But for now and for the purpose of this class, we will be using sequencing strategy #1 in our lab assessments and our lab practicals. So during palpation, what you're going to be basically looking for, the first thing you're going to be looking for is obviously pain with palpation, or what we would say is point tenderness. Where do they hurt when you touch them? And for some injuries, that could be in one particular spot, and so that could be focal. In others, it could be more diffuse, so it could be multiple spots in different areas, right? And so when we get one area of point tenderness, please don't stop your injury evaluation there. Move to other spots to determine whether or not the pain is focal and whether or not it's more diffuse in nature. We also could be palpating if we're dealing with a muscular injury, areas of trigger points, right? These are going to be hypersensitive areas within the muscle, specifically the muscle belly itself, that hurt the patient when you touch them. And we could all kind of touch ourselves right now, right around our trap region, and we probably all would have a trigger point that's kind of tender to palpation, right? And we could massage that or do some trigger point therapy to cause it to release. We also want to look for our changes in tissue density. So for example, if we have a grade 3 muscle strain, typically the muscle itself, the hamstring, is very taut, it's very tight. However, when you have a grade 3 muscle strain and there are complete tears in the actual muscles itself, what you will see is that you'll have areas of tightness, and then eventually you'll have a divot or a weakened portion of that muscle, and then it'll be tight again. So when I say a change in tissue density, what I'm really talking about is whether or not there are, divots in the muscle belly or divots in the muscle that would represent some type of strain and or avulsion injury to that particular muscle itself. We also want to look for what is called crepitus, and the best way to define crepitus is a creaky sound that you hear when your patient moves the joint. But we could also kind of equate that to the teacher who puts their fingernails on a chalkboard, right? And begins to pull their nails down on the chalkboard as we all just kind of, our ears kind of get irritated. And that's kind of what crepitus sounds like within the joint. Typically, crepitus is not a good thing. However, there is a subset of the population where crepitus is normal and it causes no pain. And so we don't try to change it. The other thing that we look for with palpation is tissue temperature. Again, as I said on the previous slide, an increase in tissue temperature after an injury, or specifically, more importantly, after surgery, could really represent some type of infection, systematic infection that's going on with your patient. So when we touch a patient, we're looking for pain, any trigger points, change in tissue density. We're also feeling for some type of creaking sound. And then last but not least, what we also want to do is assess the temperature of the pathological extremity and or limb. So after we've palpated and we determine which joint and or muscle might be painful or might have crepitus, the next step in the injury evaluation process is joint and muscle function assessment. And so again, just like with anything in the injury evaluation process, we always want to perform these tests bilaterally, and we always want to begin on the uninjured limb first so that we get a good gauge or an assessment for strength and function on the uninjured side. And so when we think about what joint and muscle function assessment is going to consist of, there are about 5 or 6 components that are huge and important. So I'm going to list them and then we'll talk about them independently on the next slide. So the first one is active range of motion, manual muscle test, passive range of motion. And we got joint stability test and stress testing. And then last but not least, we also want to assess the patient's joint play if it's applicable. And so when we think about assessing active range of motion, which is always first in our injury evaluation process after palpation, what we're going to say and what we're going to define active range of motion as is any motion that the patient can produce him or herself, right? And so, for example, if I asked you to pull your toes to your shin, you guys would all dorsiflex your feet or your ankle, and you would pull those toes up to your shin. That is something that you are actively doing yourself, right? Active range of motion is always evaluated first. Why? Because it's always nice to know what your patient can or cannot do first before you start to torque on the patient's injured limb, joint, muscle, etc. The only time we don't start with active range of motion if for some reason it's contraindicated. And the only reasons I could think of would be like if the patient has a joint dislocation, if they have some type of neuropathy, but otherwise active range of motion in the systematic evaluation process is always performed first. And so when the patient performs active range of motion, what we're taking notes on is how easy do they move through that range of motion? Are they struggling? Does their face tell you something? Is the full range of motion achieved, right? This is the big component, is range of motion full, right? Or is it limited? And if it's full, do they have pain doing it, or can they do it without pain would be the question. And then also the other question becomes, if it's full, was it compensated? Did they have to overly extend their toes to get into the correct motion? Did they have to move their hip a certain direction in order to get into full hip flexion? What was their range of motion like? Was it normal compared to the other side? Did they do the exact same things that they did on the uninjured limb? So after the patient has proven that he or she can move his joint or her joint through the ranges of motion themselves, the next step in the process would be passive range of motion, right? And passive range of motion is defined as the clinician or the healthcare professional moving the joint through the range of motion. So instead of the patient pulling their toes to their shin, the clinician then comes in, grabs the forefoot and moves that joint through the range of motion, right? And so that's different. The patient completely relaxes and the entire motion itself would be a passive movement, something that the clinician does. So what does passive range of motion do? Well, it kind of identifies available movement and pain patterns, right? Let's go back to active range of motion. If a patient has pain and has to stop midway through the range of motion, it might be that it's because they're contracting and using their muscles and they can't get to in range of motion. However, in a passive range of motion assessment, that may not be the case. If the patient relaxes, the clinician might be able to take the patient through the full arc or through the full range of motion. So it could be the case where you have a patient who has limited active range of motion, but complete full passive range of motion. And so that's completely okay within the injury evaluation process. And we'll talk about why when we get to muscle strains and evaluations. And so what do we know about active versus passive? If passive range of motion is greater than active range of motion, what we kind of suspect is some type of muscular compromise, whether that be a muscle strain, it could be a trigger point within a muscle. However, on the opposite end of the spectrum, if passive range of motion is equal to active range of motion and they're still deficient, then maybe you consider some type of capsular adhesion or some type of inflexibility within that particular patient range of motion. So not necessarily an injury like we would suspect with passive range of motion being greater than active range of motion, but more so just something within the muscle that isn't allowing it to move freely. Okay, so those are the differences between active and passive range of motion and what you might expect to see in an injury evaluation. So we've gotten through active range of motion, which is when the patient does it. We've gotten through passive range of motion, which is when the clinician does it. If the patient can withstand both active and passive range of motion, the next test that we want to perform is a manual muscle test. And as the name described, really what we're doing is assessing the patient's strength and pain provocation by isolating essentially one of the muscles or multiple muscles within a particular muscle group. And so basically what we're going to do is we're going to resist range of motion, right? And this kind of allows us to assess the strength throughout the muscle's entire range of motion. So with active range of motion, we were saying, okay, what can the patient do actively with contraction of that particular muscle? With passive range of motion, what we were saying is, well, if the patient relaxes and there isn't an active contraction, how far in the range of motion can we take that patient? And now we're saying with manual muscle testing, okay, well, now let's apply a little bit of resistance to that particular muscle and have the patient pull against our resistance, and how much stress can that particular muscle and or muscle group withstand during this particular test, right? And that's a little bit different. And so what we're going to do is, and we'll do this in lab, we're going to stabilize the patient's limb, and we're going to apply resistance at the distal segment of that particular muscle group, and we're going to grade the patient's manual muscle test. And why do we like this? Because it gives us an objective assessment. It also allows us to get a baseline measurement for which we can compare to later dates in the patient's evaluation process. So what does that grading scale look like when we're assessing manual muscle tests? So it's on a 5-point scale where a 5 out of 5 would represent a normal assessment, right? This patient can resist against maximum pressure, and we cannot break. The patient does not give up during that test. We also have what would be a 4 out of 5, which is the patient can resist against moderate pressure, right? Which is different than maximum pressure. So you lighten up your pressure a little bit and the patient can take that limb through the full range of motion. And here's where we kind of get concerned. It's when the patients fall into the 3 to 1 category, right? Because then we know that they're truly, at least that particular muscle, isn't as functional as it should be, and we have to assess and figure out where we're going to go from here in terms of rehab. So when we think about a 3 out of 5, the patient can move their body part against gravity through full range of motion. But what you might notice is no pressure is being applied to the patient, right? So there is no force being applied to that particular muscle. With a 2, you have to put the patient in a gravity eliminated position, and then they can perform the motion. And then last but not least would be a 1 out of 5. So the patient can't even move the muscle, but when they attempt to do so, they get at least a contraction in that muscle group. The one you become most concerned with is a 0 out of 5. This is when the patient attempts to make some type of movement within that muscle group and there's no contraction whatsoever. Typically we're concerned because it means that the muscle or the fibers within that muscle are completely torn and they aren't communicating, therefore the patient cannot contract the muscle. So anytime we perform manual muscle test, it is on a 5-point scale, number 1. And number 2, we have to give it the correct grade, a 5 out of 5, 4 out of 5, 3, 2, and a 1. And we want to do that because, again, that gives us rehab goals. It allows us to know where we can work within when we start the patient's rehabilitation protocol. So after manual muscle testing and functional testing, what we then do once we determine which joint or ligamentous / tendinous structure might actually be injured, we would go into our joint stability stress test. And so we think about something that's going to stress a joint. Typically these stability tests are applied to non-contractile tissue. And so the most common non-contractile tissue that we'll encounter in the lower extremity will be ligamentous structures. And so these are going to be tests that assess the laxity and or stability of the joint and the ligament holding that joint together. Joints can be classified as either normal, so they have normal movement. They can also be classified as hyper and or hypomobile. And so when we think of something that's hypermobile, we think of something that definitely is more lax than another. So that's the person who can bend their fingers all the way back to their wrist, or the person in the knee joint who is what they call double jointed, or we have the person on the opposite end of the spectrum, right? And that's the person who's hypomobile, and this is a person who is lacking mobility in a specific joint and or a muscle group, right? We're concerned about these individuals because they tend to be more prone to injury because they have lack of flexibility, they have lack of joint range of motion, which makes them pre-susceptible to other injuries. And we'll talk about those other injuries when we get into specific joints within the lower extremity. So we need to know the difference between laxity and instability. When we define laxity, what we say is, or what we're saying is that this represents a clinical sign that gives us the amount of movement or give within a joint, right? And we can kind of test laxity by using what we're going to call stress tests. And we'll give you more specific stress tests when we get into specific evaluations for specific joints. On the opposite end of the spectrum is instability, right? And so this is the joint itself, right? So not the amount of give, but the joint's ability or inability, more importantly, to function under stress. So for example, if we have a patient who has an ankle sprain and they are a football player and it requires them to cut a lot, how capable is that ankle of being able to be cutted on, or being able to do a figure eight? Can that joint hold up to the stresses and forces that are required of that athlete or patient during a functional test? So there is a difference between laxity and instability. It is possible that a patient could be lax but have great joint stability. It is also very possible that a person could be very lax and have great instability within a specific joint. So we have to be able to know the difference between the two. So when we are stress testing a ligament, what we're really looking for when we said laxity is really infill, right? So when we stress a joint in a specific direction or the ligament to determine the amount of laxity, how much give does that joint have? How much play can we get out of that joint? And so when we stress test, we really grade our stress testing on a grading scale of 1 to 3. Where a grade 1 would represent a joint that has very little laxity and is very firm in nature, right? So what you might feel when you go to stress test that joint is maybe a slight stretching of the ligament, but really there isn't any tearing of the fibers, maybe a little tiny bit. But the number one sign and symptom with a grade 1 sprain really is pain, right? And as we move down in the grades of laxity, what you'll start to see is when we have a grade 2, that infill or that stopping point becomes more soft in nature. So there isn't a block. And what that means is you can open up the joint or the two bones and there's a little bit of gapping that occurs because that ligament has been stretched. And so with a grade 2, what you tend to see is you have partial tearing of some of the fibers in the ligament as witnessed on probably more than likely an MRI. And then you get that increased play of joint surfaces. And then last but not least would be a grade 3, no bueno, grade 3 sprain of a ligament, which is a complete tearing of the ligament, right? So this ligament is no longer holding the two bones together. And when you go to stress test that joint, the motion is excessive, and the joint just opens up and you have an extreme amount of play. This patient not only is what we would call lax, but they are also considered to have an unstable joint, right? So we talked about laxity and instability. Well, this is the patient that's going to have both of those because they literally have nothing left holding those two bones together. A key component to injury evaluation, and probably a key component to this particular course, will be the special tests that are used to rule in or rule out certain pathologies within each joint. One of the most interesting things about special tests is that each joint has an assigned set of special tests assigned to it. So what that means is that every joint, every limb within the lower extremity or joint within the lower extremity is going to have a different set of special tests. And so when we get into the foot and toes, the ankle, the lower limb, the knee, the thigh, and the hip, you will find that you will have a multitude of special tests that can be applied to rule in and to rule out injury, not only to bone, but to ligaments, muscles, and or tendons, right? And so again, when you special test, it's unique to each anatomical structure. The nice thing about special testing, and the one thing that we have to take into consideration when we're being systematic, truly is that the results of your special test are always going to be compared side to side. You're always going to compare the uninjured side to the injured side. They may or may not cause pain, or some special tests that we use may be used to determine whether or not it alleviates pain, which could also indicate something going on within that particular extremity. When we report special tests in our documentation, we want to report them as positive and or negative, right? We never want to just say an anterior drawer test. We always want to make sure that it's either positive or it's negative. If it's positive, that means the patient has a suspected pathology, and if it's negative, that means that patient does not have that particular pathology that you were testing for. So what we've been talking about so far in the initial injury evaluation process is really related to the bones of the musculoskeletal system, the muscular system, the ligaments, and the tendons. However, there is another key component to the lower extremity, and that is the nervous system, right? And the nervous system that specifically supplies the lower extremity, which can become injured and compromised in either microtrauma and or macrotrauma. So it'll be a huge component to your injury evaluation when your patient is presenting with, signs and symptoms of like numbness and tingling and or loss of sensation. So it becomes vital that you as a healthcare professional know how to screen the peripheral nerves that innervate the lower extremity. And you do this with what's called a lower quarter screen. And the lower quarter screen is comprised of 3 different components. The first one is going to be the assessment of the patient's sensation within the nerve roots supplying the lower limb. It's going to be an assessment of motor function, which we kind of get when we do our manual muscle testing in essence. And then last but not least, it's also an assessment of the deep tendon reflexes that are associated with the lower extremity. The most common deep tendon reflex that we probably all know is the patellar tendon reflex. However, we will also do the Achilles tendon reflex in lab as well. And so what does a lower quarter screen do differently than the other tests that we've done so far within the injury evaluation process? Well, it's going to identify any nerve root injuries, any peripheral nerve damage, any injury to the brain or the central nervous system, and any type of underlying disease mechanism as well. This is completely different approach to the musculoskeletal approach in injury evaluation that we've been talking about for the entire lecture. So what I want you to see is that we're getting an overall approach. We're not just looking at the musculoskeletal system, we're also looking at the nervous system as well, because that is a key component to lower extremity function. And so what will we expect to find in a neurologic or a lower quarter screen? Well, any positive signs would be any patient who reports numbness when you touch a specific area, any person who reports muscle weakness when you do the motor function testing, and then any injury to the lumbar or cervical spine, you definitely want to do a lower quarter screen to rule out any peripheral nerve damage that might have occurred during the injury. So a lower quarter screen always starts with sensory testing first. And sensory testing, what we're really testing is a dermatome. And a dermatome is basically just an area of skin that's going to be innervated by some spinal nerve root, right? So what we want to do is we want to test the patient's sensation. Can they feel our touch? Can they feel light touch? Can they feel sharp touch? Can they feel dull touch, which is indicated down here with the light, the sharp, and the dull? Can they feel these things equally on both sides and similarly on both sides? It really is what we're trying to get at when we assess the dermatomes within the lower extremity. So it's important that it's performed bilaterally. So you're going to do uninjured side first, and you're going to do the injured side second. And then the biggest component to this is the patient positioning. One thing that we want to do when we are testing and doing a lower quarter screen is we want the patient to have their eyes closed and, if possible, their head turned away. And the reason we want their eyes to be closed is because we sometimes during the neurological screening, we might ask them if they can feel something, but we might not actually touch them just to test them and see if in fact they're just feeling something on their skin without us touching. So the patient must always have their eyes closed during a lower quarter screen. If you look at the chart to your right, what you will see is both the lower and upper quarter screens. But what we're going to focus on in ATR 387 is this portion right here. And so we're going to basically be looking at L1 through L5 all the way down to S4. And we'll kind of do this more specifically in lab. But if you want a detailed assessment of lower quarter screen, please go to page 26 in your textbook. And this is what will be required of you to know for this class. Again, we will have a full class session dedicated to just performing the lower quarter screen. And so first we start with sensory, and then once we've determined patient's abnormalities or deficit in sensory, the next thing that we truly want to move to is motor testing, okay? And very similar to manual muscle testing, what motor testing is going to do is we're really just going to look for any deficit in strength as it relates to the muscle itself. And so what we're going to do is be looking at whether or not there's strength within each of the nerve roots that we saw on the previous slide. And so when we do this, what we want to do is we want to be systematic. What we're going to do is we're going to assess L1 all the way down to S2 in terms of motor. And again, on page 26, you will find out that each nerve root L1 through S2 has a different motor testing for it, right? So for example, L1 is going to be hip flexion, so we're going to manually muscle test the hip flexors as a group, whereas S2, on the other hand, is going to be the hamstring muscle innervation. And so what we're going to be doing is having the patient resist with their hamstrings during this particular test. So again, each nerve root has its own motor test, and so we will have to perform each motor test individually to rule in or rule out specific nerve root pathologies. So the last component to a lower quarter screen is reflex testing. So we've done sensory, we've determined motor testing, and then last but not least, we want to determine whether or not the patient has normal, hypo, or hyper reflexive tendencies. And so what we're going to do is what your physician does when you go into their clinic for a physical exam, right? They're going to use basically a neurological hammer to test those reflexes. What they're looking for is either an increased or a decreased response to that tap or that strike. And so what they say is that patients who present with an increased response, right, they're hyper reflexive, that's the patient, you tap their patellar tendon and they kick you in the nose, then they might have an upper motor lesion, so that's a lesion within the brain. Or patients who present with hyporeflexive natures or tendencies have what we call a lower motor neuron lesion, where it's actually affecting the lower portion of the brain as well. And so the deep tendon reflex, how do we perform it? Because it is very difficult to perform on certain groups of patients just because they are not capable of being relaxed. So the big thing is the patient should look away. You can have the patient perform what's called the Dendrosic maneuver, which is where you see this patient kind of holding their hands and pulling them apart. Or you can have your patient count backwards from 100 so that their concentration is on what they're doing and not on tapping the reflex or tapping the tendon itself. You're going to always use a neurological hammer, which you see here, to elicit a reflex as opposed to using your hands or some other structure. These tools have been dedicated and created solely for reflex testing. Again, we're going to do this in lab, so I'll be more specific, and you'll get a feel for what our reflex hammers actually feel like and how to use them and what technique to use. So just like ligamentous testing, stress testing, or any other type of test, manual muscle testing, what you have here with deep tendon reflex testing is the same thing, a grading scale, right? One of the interesting things is that a normal actually gets a grade of 2. So be careful when you're grading these, that if you put a 2 out of 4, that you recognize that represents a normal response. Anything in the 3 and 4 region would represent someone who's going to be hyper reflexive, so they're going to kick you when they kick out, versus someone who is in the 0 to 1 range who either has a little bit of a reflex or no reflex at all. Now, a word to the wise and a word of caution is that some patients, you may not be able to get a reflex, and that may not really indicate that they have an injury to either the upper or the lower motor lesion. It just might mean that they're not capable of relaxing enough to get a response. So you need to be very specific if you give a patient a 0 or a 1 as to why they receive that grading. So if the injury is acute in nature and you suspect that blood flow is being compromised to the distal extremity, then what we need to do is vascular screening. And so what we're basically doing is assessing blood flow to a specific extremity. In this case, it's going to be to the lower extremities. One test that you can use on the sideline and also in the clinic that's really good assessment and very quick is the capillary refill. What you're going to do is compress the patient's nail bed and then release it. What you'll find is that when you compress it, the nail bed turns white, and then if it takes longer than 2 seconds to refill and turn pink, then you're concerned that's considered to be a positive. However, if it takes less than 2 seconds to refill, then you know that patient is getting blood flow to the extremity. So again, greater than 2 seconds to refill, you're concerned about blood flow to the extremity. Less than 2 seconds to refill, we know that blood flow is within normal limits. So the extremities are getting the amount of blood flow that they need. What we also need to do, in addition to assessing blood flow, is to assess the pulses, right, of the lower extremity. And so there are 3 major pulses in the lower extremity that we will probably focus on, and that is the femoral pulse, the posterior tibial pulse, and the dorsal pedal pulse. One thing in pulse assessment, you always want to assess the pulse distal to or away from the injury. You never want to assess a pulse proximal to it because it will not give you an adequate reading of blood flow to that particular extremity or the extremities distal to it. In the upper extremity, even though that's not the focus, there are 3 major pulses that you can assess, and that would be the brachial, the radial, and the ulnar pulse. And then last but not least, this is always my last conclusion, is that if you have an unconscious patient, you are always supposed to check the pulse at the carotid artery in the neck. So that was a very long lecture online. However, it was a necessary lecture. It is the pivotal lecture to building the base or the foundation of injury evaluation and to moving into the fun part of the course, which is truly getting into joint-specific injuries and stress testing and manual muscle testing and palpating. Before you guys can do that, you need to understand that injury evaluation, especially the initial injury evaluation, must be systematic. It must contain both objective data, documentation, good communication, subjective data from your patient, inspection, history, palpation, and special testing. A thorough injury evaluation is the key to evaluating and getting the correct assessment and or pathology. You guys will have a discussion board assignment posted on Canvas, so please go there so that I know that you listened to my lecture. You will also have a quiz when you come into class the next day. God bless you guys, and I'll look forward to seeing you in the morning.